So thank you again for coming this morning. Each year the AGM is an important milestone for your board of directors. It's the board's opportunity to report back to the members on the accomplishments from the previous year and share plans for the year ahead. And I'm excited about what's to come. This morning I'll focus on two major topics. Number one, remuneration, namely the release of our long-anticipated white paper, and internet dispensing. But before I dive into those two bigger areas, I'd like to update you on programs on other member business, including professional liability, the International Optometric Bridging Program, and managed care. Let's begin with our professional liability insurance, or PLI. So practicing in optometry the college requires us to have professional liability insurance. We do that to protect our business, we do that to protect the public. It's just something that we need to have. The OAO's insurance committee and our broker Hub International have undertaken a great deal of research and fully customized our plan to ensure that OAO professional liability program represents value leadership and continues to provide best-in-class coverage. So just to be clear, obviously I think everyone in the room knows we switched our insurance provider at OAO last year. We went through a robust RFP process. We had 5 companies come in, they presented, we chose the winner. And then we went to the underwriters. The underwriters are the big insurance companies that provide the policy. And most optometrists who maybe want to get liability insurance outside of our program will go to their broker and they'll pull the professional liability insurance off the shelf and the optometrist will take it. What we did is we took that document and we lifted the hood. We looked inside, we took the engine apart, we took the parts that we didn't like, we added parts that we felt we needed. It took 6 to 8 months to fully customize this liability offering, so this is certainly not stock. You know, a good analogy would be patience. Some need stock lenses, some need fully surface customized lenses. Your program is fully customized to your needs. So I want to make that clear because this truly is one of the best insurance programs in Canada, and we spent a lot of time making sure it provided the best coverage. This year we added the option of cyber liability. We're always looking for areas where we have increased risk exposure. More and more of us are doing our medical records electronically. Some of us are even pushing those records into the cloud. So we felt that it was important that we give an option for cyber liability. And the best thing or the most exciting thing to report is that we had no increase in premiums year over year. So now moving on to the International Optometric Bridging Program, or IOBP. The OAO believes that there needs to be a mechanism to recognize foreign-trained optometrists. The mechanism needs to be open, fair, and transparent. And that's important. Optometry in North America has the broadest scope of practice anywhere in the entire world. And as a result, we must ensure that foreign-trained professionals entering practice in Canada are equivalent to North American graduates. The bridging program began in 2007, and since that time it has evolved. But the OAO still has significant concerns, and we continue to advocate for change. The goal of the bridging program is to identify gaps in qualifications and bridge those to North American standards. The OAO firmly believes there are still significant gaps that need to be addressed. First of all, we believe that optometrists have to have a solid undergraduate science education, and we continue to advocate for that position. In fact, no science-based doctorate degree program in North America has removed their undergraduate requirements. The OAO opposes any further reduction in entry requirements proposed by IOBP now or in the future that would contribute to a further dilution of equivalency. Secondly, the OAO feels that the present IOBP program is inadequate to successfully integrate internationally trained optometrists into optometry practice in Ontario. Of the 2 bridging programs, we feel that Bridging 1, which is the shorter program, is grossly insufficient, and Bridging 2, the longer version of the program, is vastly underutilized. And OAO is advocating for an increase in the length and vigor of both of those programs. And finally, and this is an important one, we feel that every medical profession, including nurses, GPs, ophthalmology, should have their own bridging program. Because there is no ophthalmology bridging program, foreign-trained ophthalmologists are coming through the IOBP. We feel it's unfair to foreign-trained ophthalmologists that their skills are not fully recognized in Canada, and we think it's time that ophthalmology begin bridging those candidates. On a more positive note, we are pleased to see that the college is now assessing credentials of all applicants. They are also administering a new, more robust evaluating examination, which will be run for the first time in June 2015. So what used to be the purview of the IOBP program is now in the hands of the regulators. And in our view, and it still needs to play out, we'll wait and see, but in our view, that is a good thing. And finally, we're pleased to announce that the college, the School of Optometry, and the OAO, the three of us are going to get together on May 11th to discuss the program. And I think everyone, all three of those groups agree that the program has deficiencies, and we're hoping to work together and make it better. So managed care plans. Managed care plans are a form of third-party health insurance that contracts with a group of optometrists to provide eye care for plan members, typically at reduced costs. Optometrists are told that the managed care plans will direct patients from the competition, and these agreements typically do not increase practice revenue. Managed care plans commonly limit patient choice of optometrist. They limit the patient and doctor choice of suppliers for frames and lenses, and they sometimes limit the optometrist's professional judgment of what constitutes an eye exam. Overwhelmingly, optometrists in the US have found that managed care has had a negative influence on their practices and forced them to work harder, much harder, for less money. We can take a page from our colleagues in dentistry who have rejected managed care and consider it a disadvantage not only for individual dentists, but for the dentistry profession as a whole. 1 year ago in Niagara Falls, the OAO hosted a panel on managed care, featuring experts from the US and Canada. The video of that panel session is still on the members' side of the OAO website, and I encourage those who weren't at that session to set aside some time to review it. I think you'll find it very informative. OAO continues to monitor the state of managed care plans in Ontario, and we're happy to report that there have been no significant gains by managed care plans to date. OAO cannot dictate how a member chooses to practice. It's essentially your business. However, we want to ensure that you have all available facts so that if you're ever presented with an offer to participate in managed care, you make an informed decision. Optimizing optometry's role in Ontario. That's our white paper. We've been talking about this white paper for a year. It started under Dr. Farouk Khan's leadership in 2014, now past president. 1 year ago in Niagara Falls, we had a town hall with 270 people, and we talked about, some of the topics were around public's perception of optometry, awareness of optometry, access, referral patterns, OHIP billing codes. And following that discussion, the member propositions were put up on the screen, people voted on them. Can we take questions at the end? Is that okay? We'll do an open Q&A at the end. Thank you. So members voted on the propositions. A vote of 80% or more were considered important for the OAO to advance further. These propositions voted on by members form the basis of our white paper, which you have an executive summary in front of you today. The discussion highlighted an imperative for change, a call to ensure our profession can deliver optimal patient care in Ontario. And we listened. So today we're proud to provide all members, like I said, with an advanced look at the Optimizing Optometry's Role in Ontario white paper. It's a remarkable step in our evolution as a professional organization. In fact, this white paper, which is our first report in over a decade, and it may be even the most thorough report ever done by any optometry organization in Canada. Not only does it give us accurate and up-to-date picture of optometry in this province, it will also give us the basis to move forward, to evolve the way we do things, and to start an important dialogue with government and other stakeholders. Every day we hear about patients and how much they value their eyesight. Unfortunately, despite substantial government investment, and I think we found in eye care they spend $632 million in Ontario in eye care per year, it's not meeting the needs of Ontarians. The time for change is now, and we need to approach it with the sense of urgency that it demands. But the province's fiscal reality needs to be kept top top of mind. We all know we're in an era of austerity. We've been told by government that there's no new money. And we saw that when our counterparts at the OMA began negotiations. And in February, the Ministry of Health stood fast and didn't give physicians a raise. They kept their budget the same. And because there's more physicians in the province this year than last year, that essentially means that their per physician remuneration has gone down. So we needed to do things differently. And the Ministry of Health has challenged us to come up with solutions, not just demands. Solutions that are based on evidence of how eye care delivery can be enhanced, but at all times putting the patient first. And I think we now have that plan. I'm pleased to share the high-level findings of our white paper and how we'll continue discussions with government to drive change. If there's one thing that I've taken away from this year-long process of developing this report, it's that we as a profession in Ontario are vastly underutilized. This is just a taste of some of the numbers that we put around our story. We all know that Canadians place a high value on their vision, but their knowledge around eye health and vision care is limited. In fact, they are oftentimes confused as to which provider to go and see. In fact, only 9% of the public would go to see their optometrist if they had a red or irritated eye. Only 9%. And only 10% of family physician referrals for eye-related issues are sent to optometrists. Those are pretty small numbers. And third, under current provisions, OHIP will cover specialists, but not optometrists for the very same services that optometrists are able to provide to patients, often in a more timely fashion and closer to home. At the end of the day, delivering a better patient experience, that's what we do. Compound that with an aging population, and these problems become increasingly more complex. If current trends continue, we expect to see the number of people with the 4 major eye diseases, diabetic retinopathy, AMD, glaucoma, cataracts, to increase by 54% by 2031. So together as optometrists, we see more than 2.5 million OHIP-insured eye exams per year. This means that we have more contact in the eye care space than any other eye health provider. In fact, there are 4 times as many optometrists in this province than ophthalmologists. We have the knowledge, we have the resources, and we have the sheer size to change things. And it's clear that we are best positioned to be the primary eye care providers in Ontario. And it's time we make that a reality. So now let's take a deeper dive into the report. It focused on 4 key areas, and we led with urgent care because we felt that was the most compelling argument. We talked about children's vision, disease prevention and management, and seniors care. After this, so again, back to, you've got your executive summary. The white paper will be released to the public on April 28th. That's also the same day that your OAO Board of Directors and Political Action Committee will meet with MPPs at Queen's Park. So we'll talk about urgent care. Patients with urgent eye conditions often don't know where to go. We saw that with only 9% of people thinking to go to an optometrist if their eye is red or irritated. Where do they go? They often go to the walk-in clinic, family doctor, emergency room, and that typically ends up in a very convoluted, awkward journey where patients go to health provider A, B, C, D, and E, and then maybe just at the end of that journey, maybe they'll think to themselves, oh, I'm going to go see an optometrist, and they end up in your chair. And what do you guys do? And you do it very well. You diagnose them, and you treat them, and you take care of them. They have a great experience. And after you've done that, many patients will say to you, I should have come here first. How many people in this room have had a patient in their exam room say, I should have come here first? In the past week. It's a common refrain that we hear day in and day out in our practices. And our white paper, the job of the white paper was to put numbers around this story that we all hear day in and day out and frustrates us to no end. And we feel these numbers will actually resonate with government because we all know who benefits if we remove the barriers that stop patients from seeing us first. Who benefits? The patient benefits. The Ministry of Health, the Ministry of Finance benefits because we can treat them more cost effectively. And you, the optometrist, we hope that you will benefit as well, because we're going to work very hard on your behalf to push government to say, hey, if we save you money by making a simpler, more cost-effective patient journey, you need to take that money and give it back to us. We don't want to be the cheap and cheerful option. It's high time we get paid fairly for what we do. So in 2011, the Ontario government expanded our scope of practice, but not to the full extent of our education and our abilities. We are currently restricted to a 4-year-old drug list to provide treatment, and at times we must refer patients to a physician in order for the patient to have access to newer, more effective medications. Talks have now been initiated with the College of Optometrists of Ontario, so Thomas and your team, to come up with a strategy to approach government to get around this problem that we have. We've come up with a strategy that we think will future-proof the profession, meaning that any time a drug is approved by Health Canada and it falls within our scope of practice, we'll be able to prescribe it. So no longer do we have to go back to government every single time a new drug comes out. We want to future-proof, and this is the strategy that I think we're going to go with. It might take us a little bit longer to get there, to get this, but I think once we do, and other provinces have now got it, I think it's going to benefit everybody, and we can put this aside forever. Furthermore, the use of higher cost providers for conditions that could easily be managed by optometrists results in unnecessary cost to the healthcare system. If more of these conditions were handled by optometrists, then government would benefit, which is nice, but again, let me be clear, we have to demand of government that any cost savings are put back into optometry. We give excellent patient care, we see it every day in our practices, and again, it's time we get paid for it. Children's vision. We didn't forget about the children. 80% of what children learn in the classroom is visual. 25% of children in Ontario have some form of vision problem. And in fact, 60% of children with learning difficulties have an undiagnosed vision problem. We know vision and education are linked, yet too few children are getting comprehensive eye exams by a doctor of optometry. Optometrist-delivered eye exams are key to identifying conditions that are most effectively treated at a young age, some of which, if left untreated, can lead to major challenges later in life. Vision screening in Ontario is gaining in popularity, but it has high error rates. Approximately 43% of children with vision problems pass vision screenings, and less than 50% of children who have vision problems identified during a screening actually follow through with an optometrist to get an eye exam. So what can we do? Some jurisdictions in the US, and there are 5 of them, 5 US states, require an eye exam upon enrollment in kindergarten. That's a great step in the right direction, but no jurisdiction in Canada has adopted that model as of yet, which is unfortunate, as we know that these types of universal programs are the most effective in terms of cost and outcome for vision problems such as amblyopia. Our ICI Learn program, which you've had exposure to today, is a step, we think, in the right direction. Our province-wide rollout will be complete on July 1st, 2015, when Northern Ontario comes on board. So I encourage members to adopt this wonderful program in their communities and get the message out about the importance of children's vision. So disease prevention and management, the third part of our white paper. It's estimated that 2.2 million Ontarians have one of the major eye diseases: cataracts, AMD, diabetic retinopathy, and glaucoma. The cost is huge, almost $3 billion annually to the Ontario healthcare system. And from 2014 to 2016, these conditions will directly cost the Ontario healthcare system $5.5 billion, which is equivalent to the GDP of PEI. Through primary eye care, we can either prevent or greatly minimize the impact of these diseases. As the population ages, we will begin to see a sharp increase in the number of people living with these eye conditions, making patient care more complex than ever before. While we have better technology and tools, OCTs, HRTs, to diagnose and treat disease, the current funding model, the current 406, assumes that all patients have the exact same needs, which we know they don't. And as an example of that, let's look at diabetes. So diabetes is the leading cause of blindness in working-aged Ontarians. and it's not going anywhere. The Canadian Diabetes Association has projected that by 2020 there will be 734,000 new Ontarians with diabetes. The Eye Health Council of Ontario guidelines, which Derek referenced for us a minute ago, for the care of these patients with diabetes was developed by optometry and ophthalmology. It lays out in black and white the role of what each eye health professional is supposed to do. So we already have the playbook on how some of these diseases are supposed to be co-managed with optometry and ophthalmology. In the same vein, we know that the appropriate management of AMD by a primary eye care provider can significantly reduce disease progression from dry AMD to wet AMD. So the ARED study showed us that there's a 20 to 25% risk reduction in patients with intermediate AMD progressing to wet if they receive daily doses of antioxidants and vitamins. And that research is constantly evolving. But if we could just prevent 20% of dry AMD patients progressing to wet in Ontario, that would save the Ontario government $228 million. Those are hard dollars, direct costs, per year. So to frame that in context, we billed the Ontario government in 2013 $132 million. So if we can stop a small portion of patients progressing to wet AMD, we can save the government $228. That's a huge amount. And what about conditions that are going undetected? Approximately 100,000 Ontarians have glaucoma. 50% of them don't know they have it. If optometrists could diagnose just 20% of those folks that don't know they have glaucoma, almost 11,000 Ontarians would be prevented from progressing to more advanced forms of this disease. And seniors. By age 65, 1/3 of Ontarians will have some form of vision-threatening eye disease, and 1 in 9 will have irreversible vision loss. The negative impact on individuals and society on a whole is severe. Visual impairment has shown to double the difficulties with daily living, double the risk of falls, triple the risk of depression, and 4 times the risk of hip fracture. Despite this, only 43% of seniors over 65 have regular eye exams, and many of these patients now present with multiple complex conditions. Optometrists have a separate, ophthalmologists, I wish we did. Ophthalmologists have a separate OHIP fee code for the extra resources required for complex patients. Unfortunately, we don't have that. We have a 406. We're supposed to do everything inside of that 406. In short, we lack the flexibility to respond to the individual needs of seniors, even though we see them more frequently. And seniors increasingly suffer from low vision and are extremely underserved, and we can help. We have more formal training in low vision than any other health professional, and we're readily accessible across the province of Ontario. But low vision services by optometrists are not funded by OHIP. Ophthalmology has a low vision code, optometry doesn't. Still, many of our members provide low vision services to their patients anyway, but at a loss. So what's next? So our white paper has revealed challenges, but we need to view these as opportunities, and I can't stress that enough. We are going to government and decision makers with solutions, tangible ones that will benefit the patients we take care of day in and day out. We have the evidence to show how important optometrists are, how much of a difference we can make in patients' quality of life if government were to recognize that and give us the support we deserve. So now we have a license to begin a real dialogue with government, and that is evidenced by the fact that today the Health Minister, Dr. Eric Hoskins, will be joining us at 9 o'clock. And it's been many, many years since a Health Minister has addressed the OAO. So I think that's recognition that we're on the right track with our strategy. Throughout our white paper, we've made specific recommendations for improvements within each of the 4 key areas. Ultimately, these will boil down to the need for updated fee codes that reflect our expanded scope of practice and complex disease processes we are now managing, public, government, and stakeholder education to ensure patients are accessing the right care by the right provider at the right time, bringing public funding for comprehensive eye exams in line with true costs, and increasing collaboration with other healthcare providers. Some of these next steps will take time and further discussions with government, but there are immediate steps that we can take. First, let's engage the Ministry of Health to convey a working group for eye health focused on implementing our recommendations. Then we can start with beginning implementing recommendations that don't require changes to government policy or regulation, programs or funding, such as public education. For example, in the last 2 or 3 years, there's been a bit of a shift in the public's perception around the flu shot. I think everybody in this room now knows you can go see a pharmacist for the flu shot. Now, how did that happen? That was a partnership between the government and pharmacy to message the public they could get care quicker and faster if they go see a different provider. So there is the potential, I think, to maybe move the dial around the role that we do and what our scope of practice is in the mind of the public. Next, support the integration of the Eye Health Council of Ontario's guidelines around co-management of diabetes, glaucoma, and AMD. And like Derek said, some groundbreaking work has been done in this area. And finally, work with local health integration networks, or LHINs, family health teams, and other stakeholders to better integrate optometry into primary patient care. So you may be asking yourself how we plan to get the ear of government. And I'm happy to tell you that we began talking to government about the white paper in the fall of 2014, when we shared our plans with the ministry. On February 18th, 2015, 60 of your colleagues in this room were at an event with Minister Hoskins. And let me say, those 60 people did you very, very proud. They did a remarkable job conveying to the health minister, and he walked around the room and he talked to every single group of optometrists, and all of you told the same story. You love what you do, but there are huge barriers in us providing care to patients around them, knowing about what we do. They don't want to come and see us because they might have to pay. He was getting the same message over and over from every single optometrist. So I think he understands our issues very, very well. He challenged us. He's a doctor. He's very evidence-based. And he said to us, show me the evidence. Show me the proof. Give me some numbers around your story, and then we'll sit down and talk. So I'm excited about the opportunity to make some change. Given the fact that we've been told there's no new money, I think we have an opportunity to move the dial. On April 28th, the white paper will be officially launched. We'll have a special website for the white paper. And that coincides with our Queen's Park Day, where your board of directors and PAC committee will meet with politicians at Queen's Park. So the white paper is your story, and we hope you take the time to go through it carefully. Many people have spent hundreds of hours gathering evidence and quantifying what we all really believe is in our hearts. We now have the hard facts and numbers to amplify optometry's message, and it's a compelling one. We know that. Our patients know that. Our next step is to convince decision makers, and we can accomplish that together. In this report and during our upcoming negotiations, we are making promises to government about our expertise and our capabilities. So we're telling them we're really good at what we do. So I'm calling on each and every one of you in this room to help fulfill our commitment to being the primary eye care providers. It's our time to step up and deliver. So as I mentioned, you've got the 2-page summary in front of you. We ask that you keep it confidential until it's released to the public on April 28th, and at that time you'll have access to the document as a PDF on the white paper website. So we are developing a website specific to the white paper, infographic, press release, and a video, which I'll show you right now. "69% of Canadians fear vision loss more than any other disability. Despite significant government investment, the current healthcare system just isn't meeting vision health needs. As the first external review of the province's eye health in over a decade, the Optimizing Optometry in Ontario report identified considerable gaps in eye care. We must act now to ensure patients receive the best care at the best value close to home. Millions of Ontarians have a major eye disease. and vision loss costs the province $7.3 billion annually. Optometrists have the training and scope to diagnose and treat most eye conditions, and we're easily accessible to Ontarians. In short, we are best positioned to be the first source for all eye care needs. Our report focused on 4 key areas of eye health: urgent care, children's vision, disease prevention and management, and seniors' vision. In 2014 alone, there were over 100,000 unnecessary eye-related emergency department visits. Many of these visits were for red and irritated eyes and could have been treated faster and more effectively by optometrists. Secondly, vision and childhood learning go hand in hand. In fact, 80% of classroom learning is visual. Today, 1 in 4 children has a vision problem. If left undiagnosed, these can lead to learning challenges. Yet few Ontario children receive annual comprehensive eye exams. Next, the 4 major eye diseases cost Ontario almost $3 billion annually. Early detection of eye disease by an optometrist can alleviate negative effects. For example, glaucoma and diabetic retinopathy are leading causes of vision loss that require specific expertise for detection and management that can be provided by an optometrist. Finally, seniors face increased risk of eye disease and vision loss, but less than half of people over 65 receive annual eye exams, which are key for early detection. This has a dramatic ripple effect because seniors with vision loss face double the risk of falls and have difficulties with daily activities. Plus, those with low vision are likely to enter long-term care 3 years earlier. The challenges facing the current system aren't insurmountable, but they require immediate action. With the right approach, optometrists can do so much more to enhance the patient journey and broaden access to care. In collaboration with government, other health professionals and healthcare organizations, Ontario's optometrists can help. We have the solutions, we have the ability. It's time to improve eye health and patient care, and it starts today.